Hospital, and I'll be for this evening. So today we have a very interesting topic lined up for us, and that's the monkeypox outbreaks in Africa. We have recently identified several cases in Kenya, and we therefore thought that it would be prudent to highlight various aspects of disease identification and management. Our speaker for this evening is Dr. Kageso Mochankana, who comes all the way from Southern Africa. And joining us as a panelist is our very own Dr. Anne-Marie Masharia, who's an infectious disease specialist in Kenyatta National Hospital. So Dr. Kageso is a consultant pediatrician who hails from Botswana. He's currently pursuing a pediatric fellowship in infectious disease in South Africa at the University of KwaZulu-Natal. He's also heavily involved in research with over 10 publications. He has been involved in management of some of the first cases of monkeypox outbreak in South Africa, and we're quite privileged to have him share his experiences in the care of these patients, and hopefully we as Kenyans can borrow some of the practices as we deal with this new outbreak. Without much further ado, welcome, Dr. Kageso.
Thank you. Thank you very much, Dr. Omolo, for the introduction. It's actually quite a pleasure and honor to be given this opportunity to share insight. And I think it's quite a topic that is quite important to be discussed at this point in time in view of the upsurge of cases within the African context, especially in those countries that have never had any cases before. So it'll be quite an interesting one for us to go through this, and for each country also to formulate their own way of going through the cases. So I'll just be presenting on the basic clinical features and the approach in terms of how we go about in terms of handling these cases and investigating, and what do we term as a suspect, and forth. So I'll be covering all these aspects. It's not quite a long presentation, just a few slides, but just trying to cover the main important aspect. Because I believe it's the first time that we hear about mpox within our setting, we become quite concerned, and especially in the time period where we're just coming out of another huge case of a viral infection, which was COVID, in which when it came, it caused quite a lot of chaos in a lot of countries, and especially in low-resource countries within the African context, was quite a difficult disease to deal with, and hence resulting in quite a lot of mortality. So when we get a new infection that comes in, which is not actually quite new, it's an infection that has been there, but it's re-emerging. When it re-emerges into the settings and getting into places where, or countries where it's never been, it becomes quite a concern. So I did quite a little bit of a search in terms of Kenya, the cases. I noted that there was a newspaper report which reported on the 31st of July, in which they gave out a statement in which the first confirmed case was reported. And I believe it brought quite a lot of concern, a lot of fear within the health sector and within the community. And we tend also to think about ourselves that, am I protected when dealing with these cases? So we tend to be very concerned, but we'll just go through the slides and just see that this is actually one of the conditions in which, if we approach it quite nicely, they could be well controlled and contained. But also the media has its own ways of scaring us, because with this article that was published on the 5th of August in one of the newspapers, they noted that Kenya mpox case confirmed but to be deadliest, and they put the deadliest in quotes strains, which is found in Congo, in which I believe, as a layperson out there who reads this newspaper, will be very concerned to hear that there's a deadlier virus that has set into the country, and more so that we coming from COVID, and which was also deemed to be a deadly virus. It brings more fear within the community. And they had noted quite important features within the article, in which we'll go over them in the next few slides. But just to go over monkey mpox, is actually a DNA virus, which is a member of the orthopox virus genus from the Poxviridae family. And it is quite important to note that the WHO in 2022, they decided to rename this virus in view of the stigma that is attached to it. Because for people who had contracted mpox, there was a huge association between say because of its association with sexual contact in humans, the stigma came in through in which people who had it were deemed to have maybe had sexual intercourse with these primates. So because of that, the decision was made to rename it to mpox. So it's no longer deemed as monkeypox, but renamed to mpox just to reduce that stigma associated with it. So it has various clades which has affected different parts of the world, in which there's clade 1 and there's clade 2. And the clade 1 was formerly named as the Congo Basin clade, and which was basically initially found within that area. And its main characteristics was that it had very high human-to-human transmission, and the mortality rate of the clade 1 was actually quite high when compared to the clade 2. And the clade 2 was formerly named the West African clade. And you can see the interesting thing about this mpox virus is that it was named by African countries. And this was basically based on its initial areas or origins of this virus where it was initially found or isolated. So clade 2 is actually divided into two main ones, into clade 1, 2A and 2B, in which 2A usually causes a very mild illness and has limited human-to-human transmission. And its mortality is actually quite low, with approximately 1 to 3%. And then when you look at the clade 2B, it actually refers to various circulating variants which were noted in the 2022 global outbreak. So the 2022 global outbreak is actually quite well documented, especially if you look at the WHO reports. They have documented the cases as they came through. Unfortunately, as mpox keeps on re-emerging, in 2024, this year, there was another huge outbreak that was noted in the DRC and had the highest cases ever recorded, especially for the clade 1. It from the 1st of January 2023 until the I think it was about May, June, they had recorded over 12,569 cases, and the mortalities were at as high as 581 deaths, which shows that high mortality that is highly associated with clade 1, which, as the previous studies and the WHO reports have noted, that the mortality is as high as 10%, which brings us to the paper or the article that was brought out in the newspaper article from the 5th of August, in which within that article, it reads that the current outbreak is caused by clade 1 variant, which can cause more severe illness and has killed about 3% of those infected in the DR Congo. In which, in actual fact, the person the journalist who wrote this article was actually telling the truth, in which the clade 1 has high mortality and as high as 10%, and hence with also the main issue around that being the high risk of transmissibility of this virus. So this is just the WHO report, which is as far as the 31st of March 2024. As I had noted that they had documented quite a lot of cases. And interestingly, you'd see that majority of cases were within the Americans, both the North America and the South American continent. And within our African context, the DRC is the one that had quite a majority of cases, with other African countries not having any cases, and those that had cases, including South Africa, we only had about 1 to 9 cases. But with the latest in South Africa, we recently had a couple of cases in which both cases were not quite severe. They had mild symptoms, but with complete resolution of symptoms. So with the next statistics that will come out from the WHO, they will show quite a shift in terms of these statistics. You'd find that with South Africa would have moved up in terms of the cases, and other countries would also be coming up with sporadic cases out there. So it is quite important for us to understand the history of mpox, where it started, how it went across and being transmitted across the continent. So in about in 1970, if you trace the history of mpox, there was a first case of mpox that was been isolated from a human being. And interestingly, at that point in time, the first case of mpox was in a 9-month-old boy. And the evolution of symptoms on that child is that he had fever, in which 2 days later he started having centrifugal rash. And after that, the symptoms abated over time. But unfortunately, as this child had complete resolution of symptoms, and as he was about to be discharged, he demised because he contracted measles. And unfortunately, in this child at that point in time in 1970, a lot of children were not vaccinated against measles. And unfortunately, he demised due to that. But that was an interesting first case of mpox to be reported. And when they traced and they did surveillance of this case, they had noted that most likely might have been infected by one of the primates. As you can see from the pictorial representation there, that squirrels and rats and also monkeys in Africa were the habitats of mpox, and hence humans who got into contact with these would later on contact mpox. So after the first case was identified in another setting, I think the next setting was in the Central and the Western Africa, and within the DRC, they had an outbreak of mpox, in which this one resulted in more cases being noted within the context of Africa. So that explains why the different layers of mpox were actually being named after African countries based on the origins where it was initially isolated within the African context. So at that point in time, there had been sporadic cases or sporadic outbreaks of mpox within communities, but they didn't result in quite overt or severe clinical features or mortalities. One would now wonder, how did the mpox now migrate and now having more cases within the American context? So interestingly, within that, there was a person who got a pre-doc. He took it from Africa and traveled with it to the US. And unfortunately, that pre-doc was actually infected with mpox, and hence resulting in transmission of mpox to the person who transferred it across. And since that initial case of mpox, multiple cases were now being found in higher cities and such. And the mode of transmission now that was highly noted within the higher cities and the developed countries was in terms of sexual mean. As we know that mpox is actually transmitted through droplets or body secretions, and with any unprotected form of sexual contact will result in transmission of mpox. And hence, now you'd find that a lot of cases that come about, especially in developed countries, are actually highly associated with the MSM community as compared to the developing countries in which most of the cases would be due to direct contact with respiratory secretions or bodily secretions within the confined settings. So it's actually quite interesting on the historical evolution of mpox and how it got to be disseminated globally. And now, as we've noted from that pictorial representation, that we have quite a lot of people or a huge number of people within the North and Southern American context. So in terms of the pathophysiology or the pathogenesis of mpox, and as I've noted, their initial habitat are the primates, and the the different types of rest that could be found in the wild. And there could also be human to human transmission if one human is being infected with mpox. But one of the main modes of transmission, as I've noted, is with respiratory droplets. And it's quite important to understand the pathophysiology, because it helps us also in terms of when we are managing cases and doing our contact tracing, in terms of the incubation periods, points of infectivity, and such. So with mpox, as I've noted, it is transmitted through respiratory droplets, or it could be a person being in contact with contaminated mucous membranes or lesions of an infected person. This would result in transmission of mpox, and if it's a respiratory mode, mpox has high propensity of replicating within the respiratory tract of human beings, and hence it will start replicating in that area. And once it starts replicating, it will result in primary viremia, in which at this point in time of a human being, they are usually asymptomatic. It's just viral replication within the major reservoir, which is the respiratory tract, and also it could be within the lymphatic systems. So once primary viremia is complete, there'll be a process of secondary viremia, in which now there'll be a huge upsurge of viral particles being disseminated into the body. And this dissemination, when it occurs, it means that the virus will be seeded into multiple systems. It is quite important to note that mpox is a multi-system disorder in which the secondary viremia could result in seeding into the cardiac tissue, the liver, the CNS, and all the other systems they could be affected. It's not only the skin that is being affected, as predominantly we see or classify it based on the cutaneous lesions. So within this context, it's quite important to note that the incubation period of mpox is actually quite a bit longer when you compare it to other viruses. It's between 1 to 3 weeks, but predominantly the cases that you've seen, you'd find that they had quite a longer incubation period, closer to the 3 weeks period. So with the clinical features, as I've noted, most of our patients we see and they present to us with the cutaneous lesions, as majority of them, they are not overtly sick and they don't have multi-system involvement, apart from those population of people who are severely immunosuppressed, which could be those patients with HIV with very low CD4 counts, malignancy patients who are on chemotherapeutic drugs, resulting in significantly low cell counts or pancytopenia, or patients who are on immunosuppressive therapy. So with any patients who's quite immunosuppressed, they tend to have quite an overt and very severe disease. And within the patients for us that we've seen, majority of them, they don't have any underlying immunosuppressive disorder, and hence they present with more closely to a mild disease. As you've noted there with picture A, it shows the cutaneous lesions. And what is important is that there's a evolution of the cutaneous lesions. So you won't find them as like this at all the times, because they evolve through different phases based on the day in which they have started on. And we'll see this in the next slide on the evolution of the skin lesions in patients with mpox. But what is important is that we have to note that the skin lesions in mpox are quite particular, because you'd find them to be at the same evolutionary phase. So you won't find others being pustules, other ones being papules, other ones being macules. If you see that, those is not the natural history or evolution of an mpox lesions. They should be within the same phase of development. So if you look at the picture A, you'd find that the lesions there, they have medial umbilication, and all of them are at the same phase of development. And it is quite important also to note that the distribution, most of them have a centrifugal distribution in patients. And with the latest outbreak that we had, we've actually quite seen, especially within the adult population, we've seen a lot of penile lesions based because of its sexual nature of transmission that occurred in that set of patients. The set of patients that we had were a group of 3 men with a possible intercourse that they might have had. One was HIV positive and had the CD4 wasn't very bad in that patient, but because of the mode of transmission, they predominantly presented with the genital lesions as noted there, in which they would present with genital swelling and they would have the lesions as noted there in that pictorial representation. Some patients also can have oral lesions, and Mpox is also one of those pathologies or viral ailments that would affect your palms and soles. As you see from the pictorial representation there in D, that the palms of these patients are being affected. As I've noted, there is evolution of the skin lesions, and it's quite important to be able to appreciate this in your patient. Usually, the lesions start as macules within the first day or two, and within the next few days, it progresses to papules and then develops into vesicles, later on pustules, and as the pustules burst, they will now become scabs. And it is quite important to note that these lesions are infectious at any point of evolution. And reiterating the fact that I've pointed out within the previous slide is that the lesions of a patient will be almost within the same phase of evolution. So you wouldn't find them in different phases. If you find that, we should also entertain other differential, especially within the pediatric context in which there are other multiple differentials that you would need to entertain and rule out before sticking to a diagnosis of Mpox. So as I've noted, it's actually a multi-system disorder. And if we remember the pathophysiology, that there is primary viremia, where there's a viral entry into the body, either through the respiratory tract or through the mucosal areas, and replication within the respiratory and within the lymphatic tissue. And secondary viremia results in where you have that high viral load, and then it will start seeding into different organs. So as you can see, that it's actually a very bad multi-system disorder, especially in patients who are quite immunosuppressed, because it basically affects all the systems. You can have encephalitis as from Mpox. It could result in ocular infections, oral infections, as you've noted in the previous pictorial representations. The patients, they can have the same lesions also orally, and they will present with lymphadenopathy because it's a sign of viral replication and maturity, and they can present with myocarditis, with the virus seeding into the myocardium and having some cytopathic effect within the myocardial tissue. And they could present with a sepsis-like picture. And genitals also, as I've noted previously, they could be affected, and GI and muscles. As you can see, it's multi-system, and it could range in different presentation. But what is quite important is that most of them present with the skin lesions, which are quite easier to identify based on the characteristics, and that will warrant further testing based also on the exposures of these patients. Within the context of pediatrics, there are a few studies that have been done to see the disease evolution and the types of symptoms that commonly present within our context. And the largest study was this study that was done by Sanchez and his colleagues, in which they looked at 86 patients, which was one of the studies that had quite a large volume of patients, just to see which symptoms occurred predominantly in these patients. And when you look at the study, none of the patients within the pediatric context developed, none of them developed severe symptoms. And they had pointed out, which is quite important, within our pediatric population, majority of patients, 100% of them will present with rash, which is the rash that I've pointed out in the previous picture and with the evolution as I've pointed. And within that paper, they classically pointed out that the patient had that evolution of the rash. And secondly is fever. And thirdly is lymphadenopathy. So these were the three main features that the patient presented with: the rash, fever, and lymphadenopathy. And if we are faced with these kind of presentation, it could be anything else. And there are so many pathologies that could present with this within the pediatric context. And hence, we have to be quite thorough with our history taking in order to identify the risk profiles for our patients. As we know that with infections, history is one of the main key areas to see if there's any risk factors for a patient developing a certain pathology. So as I've pointed out, the differentials, they are quite broad. And within the pediatric population, we know that majority of our patients tend to present with viral exanthems, in which they might have the same clinical presentation. And hence, as part of our consideration, as part of our history, we have to get specific history to try and rule in and rule out these ailments. And we have to look at the risk profile, disease progression, evolution, risk factors, and contacts of these patients in order to rule in and rule out these ailments. So we see that there's actually quite a lot to consider when you are dealing with the case of a child who comes in with a rash. And as I've noted from the previous study, most of their patients presented with fever, rash, and lymphadenopathy. And if you look at all these differentials here, majority of them would have the same presentation. So it is quite important to get proper history and exposures in order to classify your patients. So in terms of classification, how do we get to classify them? So there are three modalities in terms of, I think it's generally the way in virology patients are being classified in terms of risk category. So we have your suspected cases, you have your probable cases, and you have your confirmed cases. And these are the criteria that you'll be considering to classify patients as this. So for your suspected cases, you need a person who is a contact of a confirmed case and in 21 days before the onset of signs and symptoms. And it is quite important to note this 21 days. And going back to that pathophysiology, that your incubation period ranges from 1 to 3 weeks, which is 21 days. So during that incubation period, a patient will still be quite infectious. It's not only when the lesions appear, they would be infectious from the time of onset or time in which they contact the infection, because it will still be primary viremic, but at that point, they'll still be infectious, even though the viral load wouldn't be as high as the time period of secondary viremia. So if a child has any contact of a person who has mpox within the previous 21 days, presenting with headache, fever, lymphadenopathy, myalgia, back pain, profound weakness or fatigue, or a person who presents with unexplained acute rash. And this is quite important, in which you have to also try to rule in and rule out other viral exanthems that could have the same presentation. And they present with lymphadenopathy and mucosal lesions. And you can see all these clinical features that these are quite non-specific clinical features. And this could be any of those differentials that we have pointed out in the previous slide. And commonly, it could be any viral exanthem, which could be from your HSV, your human herpes virus 6, 7, or any other like measles and such. It could present within the same manner. But what is important is the second aspect of your suspected case, that they also have to meet this criteria, in which the following causes have to be ruled out or not being explained by the rash or the clinical presentation of the patient. The patient should not have varicella, herpes zoster, measles. In other areas such as the South American population, where they have a lot of Aedes and resulting in Zika infections, Zika will be considered. Dengue within the contours of Africa, as I've seen that with the within the past few years, dengue has been quite predominant, chikungunya, herpes simplex, and bacterial skin infections. These, if you look at these infections, they are part of the differential list as I've pointed below, and hence, as part of clinical assessment in pediatrics, we have to rule these out. And the way in which we approached our cases here was that from the point in time of clinical suspicion, it's difficult to rule out these ailments, and hence we will put the patient as a suspected case and do viral workup or viral swab for these ailments, especially for our VZV, HSVs, in which would present with the typical or similar skin lesions. So we would take samples, send them to the lab for these, inform the lab that this is a patient who presented with these symptoms. You are concerned of mpox, but we would like to rule these out because we'll see later on that there is a specific way in which we need to be handling samples, and we need to be handling them with care because they are high, they have high propensity of transmission to the healthcare workers and the lab workers. So in terms of a probable case, a probable case is a person now who meets that criteria of a suspected case and has one of or more of the following clinical features, in which one has an epidemiological link, in which we classify that by either a face-to-face exposure with a person who has been a confirmed case of mpox, or us as healthcare workers, in which we would approach or start assessing a patient without proper PPE, such as our gloves, our face shield, our or goggles and respiratory protection, because that means that we would have been exposed. And this pathology, as I've noted before, is also transmitted by respiratory droplets. And if we get in close contact of an infected case, there is a high risk of transmission within that context. Or we get into contact with the skin lesions of a patient with mpox. That is one of the high risk exposures, and they qualify to be under the third category of being epidemiologically linked to a case. And within the adolescent and adult context, sexual encounter with a person who has active lesions of mpox would also fall into that category. And as I've noted, it is quite important to note that transmission could also be with other ways, in which if there are clothes that have been in contact with active lesions, that means the virus will still be within those clothes. And a person who gets into contact with those might be also at risk of getting infected. The bedding equipment, the clothes, the kitchen equipment that this person uses, those are the risk factors for transmission. So if you think about it within the clinical context, it means that the anyone who would be in contact with the linen of that patient, the clothing, the kitchen utensils, anyone who cleans the room for that patient, including the toilets that they use. And if it's a shared toilet, that means everyone who has been to that toilet where this patient who is actively infected goes to would be at risk. And we would classify this patient under epidemiological link if they present with clinical features that meet the category for a suspected case. And travel is also quite important. If it's someone who has traveled to a place which has or which is endemic to mpox within the previous 21 days of onset of symptoms, those who fall within the category of MSM would be considered as high risk, and a positive result in terms of serology. And note that this is not PCR, but just a serological test positive for the orthopox viruses would classify within this category. And with serology, we know that we have to dish in out that this patient has not been vaccinated within the past month or so, because they would still test positive in terms of their serology. But within the African context, I'm not sure of any country which is still giving the pox vaccines, unless it is those that have been given as part of post-exposure prophylaxis to a case of mpox. So now with a confirmed case, this is now where we say a patient who meets the criteria for a probable case and also has a laboratory confirmation, in which the confirmatory mechanism or mode for this one would be to having a viral DNA positive through PCR or nucleic acid amplification testing, or in labs that offer sequencing, those that have sequencing done that is positive for mpox. So that's in a nutshell the definitions for our suspected, probable, and confirmed case. So it is quite important for each country to devise their case investigation forms. And this is the case investigation form that we use in South Africa. And usually a clinician who gets a case and is highly suspicious that this could be a case of mpox, and looking at the diagnostic criteria and taking in that this patient could be a suspected or a probable case, then they would first thing would be for them to fill in the case investigation form. And in South Africa, we actually have an infectious disease WhatsApp line in which we respond at any point in time. They can post that they have a suspected case and pictures of the lesions. We would inspect those and give advice if further testing needs to be done for that patient. But a case investigation form will need to be filled, which basically looks at the the details of the patient, the clinical features, the risk profile in which, as we've noted before, and the contacts and travel history of the patient. And in essence, is actually trying to dish in and dish out to see if this patient meets the criteria for a suspected or a probable case. So after that discussion with us, and after careful considerations and looking at the skin lesions and the clinical features of this patient, if we are highly suspicious of an mpox, then we would suggest sampling, in which it is quite important to note that with mpox, it is a category A disease. It's the way in which we collect the sample. It is of a category A, in which I'll discuss further what I mean by category A. So for us to collect samples, we need to get viral transport media, and then we need to get the swabs, the swabs, which these are the same swabs that we use to do the nasopharyngeal aspirate for COVID. And it's important to note that if you don't have viral transport media, it is still okay to use the swabs. And do not put the swabs into the media, which is gel, because the gel affects the PCR. Your virology department is not going to run that if it's put within gel. So if you don't have the viral transport media, just swab the lesions with a dry cotton swab and put it in a container and send it directly to the lab. Don't put anything else, no gel, no any liquid within that. So, and that sample has to be transported immediately to the lab if it's not within a viral transport media. And the one that is within the viral transport media, the media preserves the viability of the virus, and you can it can be viable at least for the next 48 to 72 hours. So it brings more longevity to the virus, so that you can be able to be assured positivity if the virus is there. So the first step is to use your swabs, swab the lesions, as noted there. It is important that you don't forcefully de-roof or anything. Just swab the lesions, because those lesions, they have very, very high viral load. So with just a single swab of the lesions, you'll be able to get positivity from them if a patient is positive. And this is what I called the category A sampling or shipment. It's a triple packaging system. As you can see there, I don't know if I can do a laser. So this is your sample and has to be triple packaged. And the meaning and the whole reason around triple packaging is protecting the people who will be transporting or receiving the sample from getting infected, because you have your sample, and around your sample there has to be an absorbent material in which, if it happens by any chance that the viral transport media that contains your sample spills, the absorbent material will be able to absorb that fluid and avoid it spilling to the rest of the container, and increasing the risk of transmission of those who will be handling the sample. And then it you take it, put it within, with your absorbent material, put it within your first container, and then after that you put it in the second container, and put it within the third one, and send it to the lab. So it's triple contained. So you have the sample, the absorbent material, the second container, and your final box to be sent to the lab. And it has to be carefully labeled that it's a hazardous sample that has to be sent to the lab. And it is not any lab that will be able to take your sample. This is very important, because we would want to protect anyone who gets into contact with the specimen. In an ideal sense, a category, a BSL class 4 lab is the only one that should be able to handle your specimen. And this means that within the context of South Africa, there is only one national lab that will be able to handle that, which is our NICD. And this is the type of equipment or clothing that they will need to use to protect themselves, because the sample is quite infectious. So that means that it has to be transported immediately to this unit, and this is the only unit that will be able to open the sample and process it for testing. So just going back a little bit, in instances where we don't have this box, what can we do? So we've had instances where we don't have it, and we have try to improvise, but trying to create a mode that is as safe as possible and closer to the ideal way of sending the sample. So you can take your sample, and this would be betterly off used without the viral transport media, because the VTM carries the risk of spillage. So we've taken a swab lesion, put it in the first container, and put an absorbent material. And in improvising, we've used cotton. You can use cotton on your container, and then put it in the first container that is sealed, in which you can also seal it with your sellotape to avoid it spilling, and find a sealed box in which you put the whole container within that box, and label it that it's a hazardous material, and send it to the lab. I understand that within our confinements in different hospitals is not always that we'll have the ideal resources to be able to do this, but we'll have to find means and improvise so that we get our patients being tested. So now we have our patient, we have collected the swabs, and what do we do with the patient in that instance? There are important precautions that we need to be put in place. And the first thing is isolation of our patient. And we need to protect ourselves. We need to protect any other healthcare worker, and also the support staff within the hospital, which is inclusive of the cleaners, the porters, the kitchen staff, and anyone who could be involved in handling any substance, either clinical or non-clinical waste that comes from this patient. So we have to isolate the patient. In isolation, it means that we put the patient in a secluded room or dedicated room, in which there should be proper measures on entry and exit. So on entry, a person should have proper personal protective equipment, which we'll talk about it in the next few slides. And there should be limited or restricted access to that area. And hand hygiene is one important factor that we need to bear in mind at all areas. It has to be practiced when entering and also when exiting a room of a person who is as infectious as this one. And in terms of isolation, it is quite important to note that some patients can also be isolated at home, especially those that are asymptomatic, because our hospitals have capacity. And if we have an influx of cases, we cannot be able to isolate everyone within the hospital context. So we can isolate at home, making sure that they have limited contact and limited access to other people that are not sick with mpox. And the duration of isolation, it's actually quite varied, because when you look at the studies that have looked into this concept, they are actually a bit inconclusive. But the consensus around isolation is that a person should be isolated at least up to 2 to 4 weeks. And care should be put and make sure that all the skin lesions have completely healed, and even ensure that at least a new skin layer has started developing in that patient. That would at least ensure that this patient is not infectious. So in terms of personal protective equipment, as I've noted, every healthcare worker should have gloves, gowns, surgical mask, and eye protection when entering a room of a patient who is confirmed or even a suspected case of mpox. And it's quite important that on entry, hand hygiene should be practiced before donning in your PPE, and hand hygiene has to be put in place also when leaving the room of a patient with mpox, either a suspected or a confirmed case. So with regards to contact, because now we have the patient, we've isolated the patient, and we've put in our standard and contact precautions, what do we do with all those that have been in contact with patients? And starting off, how do we define a contact? What is a contact? So a contact is basically any person who have come into contact with a suspected case or a probable case or um, a lab confirmed case, and has been in contact with that person without appropriate personal protective equipment. It could be either the people that are living with this patient, and we should actually remember that we're not just checking immediately those who have been in contact with. We should also project back and look at the previous 21 days on where this patient has been, how many people has he been in contact with, and if he has sexual partners of this patient, and such. And we start contact tracing from that point. And we look at these patients and we do evaluations with history and see how many of those are symptomatic and how can we isolate them. And for those patients who are asymptomatic and we classify them as contacts, we can isolate them for at least a period of 21 days and monitor them for disease evolution, because we expect that within 21 days of a contact, if a person is to develop symptoms, they have to develop within that confinement of 21 days. So we'll be monitoring them. So there are different modalities of monitoring depending on how you trust the patient, the resource availability within your area, and such. If we have limited space in which we can put our contacts, they can be monitored at home. And then we can do self-monitoring of patients. So in actual fact, when you look at different settings, within South Africa, we have a self-monitoring tool for patients in which they would fill in their symptoms every day to see if whether they are developing any new symptoms. And if now they see changes or start developing skin lesions or feeling sick, there's a phone line in which they will call for further clinical assessment and evaluation. And in patients who are unable to do that, there is telephonic monitoring by healthcare workers every day, in which a healthcare worker would call the patients and run through the checklist to see if whether there's any of those symptoms developing. And they also could be face-to-face, but this one it tends to be quite taxing for healthcare systems because we don't have quite a lot of manpower. We always have shortage of healthcare workers within our African context. So what usually works quite better is the telephonic and the self-monitoring um, the self-monitoring part. So in an ideal sense, in our last release in South Africa, we had pointed out that there is no need for isolation for asymptomatic patients unless they start showing symptoms. But I believe that with progression and as the case start increasing, we would even adopt a more strict policy in which anyone who has been in contact, regardless of the symptoms, either symptomatic or asymptomatic, will need to isolate for a period of 21 days. But currently, our protocol in South Africa is that they don't need to be completely isolated, but they will be monitored. But in an ideal sense, if you look at the CDC guidelines and such, they preach a lot of isolation for asymptomatic cases. So now we have our patient in our confinement, we've isolated. Whom do we treat? In general, majority of our patients, we do symptomatic relief and we don't offer any form of treatment. But if a patient presents with a multi-system disease, that's a clear-cut indication for treatment. And also, if a patient has underlying ailment that could increase the risk of having a severe disease, and this entails those patients who have HIV with a CD4 count less than 350, um, those patients with malignancies, those patients who are on immunosuppressive therapies, our pediatric cases with inborn errors of immunity, those are patients in which we'll be leaning more towards treating. And as far as the CDC is concerned, their approach is almost similar to what we have in South Africa, in which they treat only those who have severe disease, and the approach is almost similar to that was put in place for smallpox back in the days. So the treatment modality that is there is called tecovirimat, and it's in two formulations, as oral and IV formulation. This is actually, when you trace back on time, is actually a treatment modality that was approved for smallpox. But because of similarities of smallpox and mpox, this drug is effective in treating patients who present with mpox. There's actually a very large study that is currently ongoing in the US, and they're trying to look at the efficacy, because we haven't had like a proper efficacy study of tecovirimat in terms of mpox, but we have that in terms of smallpox. So there's that big study that is currently ongoing. So the downside is that tecovirimat can only be used on children who are more than 13 kg, so which disadvantages those that are less than 13 kg. But we believe that this could be on a case-by-case basis and assessment of risk benefit for those who are less than 13 kg if they present with a severe disease. An alternative is brimsvidofovir, which is the brimsvidofovir is also an analog of cidofovir. So we could either use cidofovir or brimsvidofovir. The brimsvidofovir is only available in oral formulation, and cidofovir has the IV formulation, which we can use and has also showed some efficacy. And these were also approved for smallpox, and we're extrapolating the smallpox treatment because of the efficacy in terms of treating mpox in this state. So for those patients that are exposed, what do we do for them? So the main issue around those patients is post-exposure prophylaxis, and this puts healthcare workers within the brackets for people who will be eligible for post-exposure prophylaxis. So the post-exposure prophylaxis, we usually give it within 4 days of exposure and can reduce disease severity if given within the first 5 to 14 days of being in contact with a patient who has mpox. So this is even before the patient start manifesting with the signs and symptoms. And there's the MVABN vaccine, which is given in a two doses 4 weeks apart, which could be given to those people who have been exposed. And note that this is a live attenuated vaccine. So all those contraindications for live attenuated vaccines, they apply in this instance. If the mpox becomes a huge problem, in which currently I don't think it is, but if we start having a lot of cases emerging through pre-exposure prophylaxis is one of those interventions that we'll need to deeply start thinking of, and especially looking at certain populations. In our African context, we have a lot of HIV patients. We need to look into those as part of the category of patients that will be possibly offering, and other immunocompromised patients, those patients that engage in high-risk sexual behaviors, the MSM, the transgenders, and such. Those will be those that we put in the high-risk category in terms of consideration for the vaccine. But in this instance, because it's just a few cases that we have that are quite sporadic with no major outbreak factors, we're not yet there where we would be thinking of pre-exposure prophylaxis. But in terms of post, we can offer, we can provide, and it's not yet available in South Africa. Is not yet available. I'm not sure within the Kenyan top context if the vaccine is available. It's the same vaccine that was basically has similarities with the vaccine that was used for smallpox. And those patients or those people who had mpox vaccine, that actually they have some level of immunity against mpox. So it's unfortunate that for all those generations that came after the smallpox vaccine, we are at the highest risk of infection and clinical manifestations due to mpox. But these are the interventions that are there that could be offered as a form of prevention. So for patients that we have started treatment, we need to follow them up and see how they are, and especially those who are presenting with severe symptoms. And one of the major issues of follow-up is looking at development of new lesions whilst on treatment, in which in ideal sense, these patients, while we started treatment, they should have a trajectory of improvement in terms of this disease process and the skin lesions. So if there is development of skin lesions or worsening of the disease process, we need to start thinking of PCR testing of the new lesions to see if we're still having wild viral replication within that patient. And that could mean that we need to start thinking of, is there any possibilities of tocovirimat resistance, our PKs and PDs going nicely into that patient in terms of administration, metabolism, excretion of the treatment modality in our patient. And we need to do our serology just to check the immune response in that patient. And we need to think outside the box in terms of the patient, is whether have they contracted a superimposed bacterial infection, because this patient has lost the skin barrier which offers protection in terms of other infections. So with that, that is basically the approach to mpox in terms of having a case. And I hope the approach was helpful, and I'll be happy to get into a discussion and also get to answer a few questions that you might have about mpox. Thank you.
Thank you so much, Hageso. That was a brilliant presentation. We do have several questions, but before we go into the questions, I'd like to invite Dr. Anne-Marie Macharia to just give us a little bit about the Kenyan experience.
Good evening, everybody. Thank you, Dr. Kagiso. I think that was a really great presentation that was able to take us through the clinical features of mpox, how to diagnose it, how to manage it. I like that you touched especially on the aspects of IPC Um, we haven't really had patients at our national hospital, which is where I work, because Kenya has just started to identify a few cases and none have been managed at Kenyatta National Hospital. So I think this CME has come at a great point in terms of us as healthcare workers, having preparedness and really this sharing of experiences with our neighbors should help us to prepare better. As I listened to Dr. Kagiso's presentation, there are just a few things that I wanted to emphasize, and maybe that's what I'll touch on. So in terms of identification, because I think this is where a lot of healthcare workers, I could already see some of the questions in the chat box. We've said that because this is a viral exanthem, it is very similar to other viral exanthems that are common, particularly in the pediatric population. And the constitutional symptoms, that fever, myalgia, fatigue, again, presents with many of the illnesses that children are presenting with. So I wanted to just emphasize varicella because we have been having outbreaks of varicella or chicken pox, and that one can quite closely resemble the lesions of mpox. So in varicella, the lesions tend to be centripetal, meaning they're concentrated a lot on the trunk and they're less on the extremities, and they tend to spare the palms and soles. And you can see that mpox is a rash that can quite often involve the palms and soles. And the lesions that you get in chickenpox are umbilicated, initially vesicular lesions before they get that dimple, looking as if there's a little dimple or umbilicus in the middle of the lesion. And they tend to progress quite quickly. So that from evolution of those initial vesicles to you getting the umbilicated lesions to then the crusting over happens quickly over a 24 to 48 hour period, in contrast to mpox. And for a healthy child, they will not have a lot of constitutional symptoms. So you will not expect the child to be looking very moribund or very ill. So one differential to keep in mind, and often for the baby with chickenpox, you can identify a contact or you can know that this baby had not been immunized against varicella. Measles was mentioned, but I think we're more familiar with measles. Again, we have been having outbreaks of measles, more of a maculopapular rash, meaning you have macules, which are flat, non-palpable, reddish-looking lesions mixed with papules, which are raised lesions that are less than 1 centimeter across. And again, the distribution coming from the head down to the trunk and to the legs. And as it spreads, you have the lesions that are on the face drying up. And we remember the conjunctivitis, coryza, and other things that are associated with measles. So I think for us as healthcare workers, just starting to revise the case definitions of these common childhood exanthems so that we can identify cases with a bit of confidence. And even as we keep mpox at the back of our minds, I'd say not to panic because we haven't really had a lot of spread of mpox within the country. Molluscum contagiosum is another one that comes to mind, something that we see especially in HIV-infected children or children who have some immunosuppression. And for molluscum, unless the child is immunosuppressed, the lesions are not widespread and there's usually no constitutional symptoms. Yeah. So those were the three that came to mind as differentials that you may need just to look at. Doc again emphasized who are the populations at risk. So our immunosuppressed children are the ones who we may need to look at. And for us, even the children with severe acute malnutrition will fall into that category, as well as all the other children he mentioned, those who are on chemotherapy. He mentioned children with endocrine disorders. So to look at those, but we had a seminar that was talking about mpox in adults. And one thing we really wanted to emphasize, in countries that have a high HIV population, let us not also cause panic amongst the HIV infected patients, because as long as their CD4s are good, they have a good immune reconstitution, and they're virologically suppressed, their risk is not much more than the general population. Looking back at our experiences in COVID, I think whenever there's this outbreak, and Doc emphasized the role of the media, our role as healthcare workers in terms of building confidence and reducing panic, mpox is yes, it's a disease that spreads easily, but in terms of infectivity, it is not like COVID, for example. So while there's the respiratory droplet, that is a smaller proportion than the direct contact with these lesions, particularly when they're still wet. So as long as the healthcare worker is practicing good IPC, there should not be panic around children, because really we saw that majority of our deaths before we really got ourselves organized in terms of managing COVID would happen because of other reason. So the child comes in, they have dehydration, a positive COVID test, we do not even manage that GE. So let's not fall into that trap, especially because majority of the cases of mpox will be mild, and the care is largely supportive. So I think a lack of panic needs to come in. We need to be prepared in terms of if a case should present, you should be able to manage it in your health center. We do not want to be moving children around, starting to transfer them to Kenyatta, because that is also going to increase the cases of spread. So the recommendation is actually that children should be managed where they're identified. So it's to start to ask yourself, do you have facilities for isolation? So the child can be put in a single room. If you have more than one case, those cases should be cohorted together. And Doc has laid out quite well what the PPE is that you require, which is a face mask, a goggles or shields, a gown and gloves. And of course, hand hygiene is number one. And especially if you're able to do washing with soap and water, or even just the sanitizer. And that should be something that we do regardless of whether we are dealing with Mpox or not, because you don't want to be instituting these measures only when you have cases. So hand hygiene should be something that we're always practicing within our health centers. Let's think about, if we do get cases, where can we isolate them? How will those children be nursed? Do we have adequate PPE? And even if we're doing this within the community, what is the advice that we can give family members in terms of caring for a person who is affected within the household? So I think for me, those are the things I really wanted to emphasize. But thank you, Doc. I also just enjoyed that presentation. In case anyone asks, I don't think in country we have these antivirals widely available, the ones that are being used for severe disease. Within the private facilities, you may find tecovirimat available and maybe even cidofovir or trifluridine for the patients who are having ophthalmologic presentations. But these are not things that are commonly available in our government hospitals. So as we look at the scale of what this will look like in the country, that along with vaccines is something then that will need to be considered. But at this point, it is not widely available. Thank you very much.
Thank you, Anne-Marie, for those very relevant comments. And you have answered some of the questions because people are already asking on the availability of treatment. So back to you, Dr. Kageso. One of the first questions is a swab of the skin surface sufficient, or is there a need to get a sample of the fluid and the roof?
Yeah, just a simple swab of the skin lesion is actually quite enough. You don't need to um, like get the tissue sample or anything. You just get your dry swab and then you just swab along the lesion and send it to the lab. It's a PCR test, so it's highly sensitive. And as I've pointed out, these lesions have very high viral load. So you don't need to cause much of harm to the patient. Just a single swab will help.
The second question is, what's the doubling time now that we've had some cases, and what's your experience would be the potential or outlook for the current outbreak, which I guess would be in South Africa. So what is the doubling time?
Yeah, so there's limitation of studies that looked at the R naught for Mpox, but on average, because of the significant variability, I think it ranges between 1 to 3 per single case. So a single case might infect about 1 to 3 more people within the community. But it's like I've said, there's quite significant limitation because of the disease process in itself, that we haven't had quite a lot of patients with it. And even with the contact tracing that we've done in our patients, we haven't had majority of the patients came back negative. We've had quite a huge cohort of contacts, but upon questioning and observation, majority of them didn't have Mpox. With our last outbreak, like I pointed out, we had a total of 3 patients, and we tested quite a lot of their contacts, and none of them had any presentation. They were completely asymptomatic. So we just did the daily questioning just to see their symptoms and all that. So it's way less infectious when you compare it to COVID.
Oh, thank you. The next question is, for the elderly who happened to have received the smallpox vaccine, are they protected or partially protected?
So in actual fact, is partial protection. You're not 100% protected. It only offers partial protection, and hence it tends to reduce the severity of the disease process also.
Okay. And there are several questions that are related to pregnancy. Have you had any experience handling pregnant women who happen to have smallpox? And is there anything different in their management?
Okay. And unfortunately, within our confinement of pediatrics, we would be dealing only with children. But in just thinking about the disease process, I don't think it'll be any different. But the only thing is that when you're offering post-exposure prophylaxis, because of the vaccine is live attenuated, you can't offer that to a pregnant woman. But in terms of monitoring and following up the patient, I don't think there will be any issues around that. With severe cases, we haven't had any in South Africa, but I'm not so sure if tecovirimat is being approved in pregnant women, because I know with pseudoephedrine and brimcidofovir, they are quite toxic and they can cause quite overt renal injury. So it has to be the worst case scenario of risk benefit, and with consent from the family or the patient.
Okay. Okay. And then another question is, do the lesions usually heal with permanent scarring or not?
So with the ones that I've seen, they don't have any permanent scarring on patients. After some time, the skin regenerates and you have normal skin afterwards.
Okay. Some of the questions being asked, I think you have answered them live. Like there is a question on how you handle asymptomatic contacts who are non-positive. I think you did mention that quarantine for 21 days, and you can do they can do self-reporting or telephonic follow-up. Dr. Anne-Marie, there's a question for you as to whether we have a lab in Kenya that's able to test Mpox. And I think you already answered the question about medication. Could you maybe tell us about that?
Yes, so currently the National Reference Lab in Cambridge have capability for testing. So that is where you'd refer the samples to.
Okay, thank you for that. Dr. Anne-Marie, there's another question, but I think you've answered this one. Someone is asking, where do we refer the patients to? But you have emphasized that they should be managed at their referral facilities unless it's a severe case. So I
Yes.
think most of the other questions have been answered. There are a lot of congratulatory messages for you, Dr. Kagiso. Thank you so much for that brilliant presentation. So before we end, I'll just give you a chance to give us any last comments.
Thank you. Thank you very much. It's actually a pleasure to be discussing this topic with you, and it's sharing insights in terms of such condition within the African context. And I'll be happy to be invited further for any other talks that you would like to share, because we are in different points of Africa. So it'd be quite interesting to share insights on such emerging conditions. Thank you.
Thank you very much once again for that brilliant presentation. And thank you everyone for tuning in and for the great number of participants that we have. Have a good evening.
Good evening. Thank you.
Thank you. Bye.
Bye.